It's a huge pleasure and an honor to have Erica Cini speak to us today. Erica graduated from the Malta Medical School in 2005 and did her training in the UK. In our field, she's one of the most senior consultant psychiatrist in eating disorders field at ARFID, East London Foundation Trust. Has got an honorary professorship, associate professorship with UCL, and recently started at King's as clinical senior lecturer, running one of the principal MSCs in child mental health. With that, over to you, Erica.
Thank you very much, and thanks Dennis and Francois for inviting me today. So I was asked to present on an overview of eating disorders, and I was told that the audience will mainly be school professionals, and there might be a couple of parents joining us. Overall, I think what I'm going to be covering is the overview in general about how to recognize eating disorders. I'll touch on some of the management, but I won't go into too much detail because I can speak forever about eating disorders and I won't do it all justice in 1 hour, but I'll do my best. I've added some extra slides at the end which go into more detail around the management, and I've given a bit of a summary around the NICE guidelines so those you can read in your own time. And okay, so let's get started. So just thinking about what we'll be talking on in this session, and we'll be thinking about how can we see and describe when a child has normal eating, disordered eating, or eating disorders. Is this part of adolescence? Is this a bit more? Do I need to get worried? Do I need to be on the phone to our local CAM service or our local eating disorder service to ask for help? So hopefully we'll tease those bits apart. And as we know, from very young children all towards, and then again in teenagers, there can be fussy eating. They can all get a bit aware of their body weight and shape. But when is this really a problem? I then want to move on to thinking about the eating disorder epidemiology and just giving you a brief overview about etiology, prevalence around this disorder. Thinking about, should I jump straight on the phone to mental health services? Do I need to call the GP? Do I need to think about the pediatrician? Could it be anything else? What's causing this weight loss? Thinking about differential diagnosis. And finally, when we recognize an eating disorder, what are the red flags? When should we be very worried, and when should we think, okay, there's a bit of time, not too much time, because we know, and the evidence shows us that the sooner you start having and recognizing the symptoms from the onset to when you start treatment, the less entrenched they are and the better the prognosis is. But when do I really need to be alarmed? So let's start off with the first basics. Let's start off with the first bit, which is what is normal and what's an eating disorder. So actually, a normal eating is very flexible eating. It can vary on day. If there is Christmas coming up, or Eid, you might eat a bit more. And there might be times when you might not feel so hungry and you might decide to eat a bit less. And that's normal eating. You might also think, actually, oh, I quite fancy that. And it might be, you might indulge in some higher calorie food, and that's absolutely fine. Sometimes we use eating as part of managing some of our emotions, and you might find yourself eating a bit more, a bit less, depending on your mood. And as long as it doesn't go into extremes or for a long period of time, or becomes a pattern, that again is quite normal. There might be times, as I said, you can eat a variety of food. You might change what you like to eat. But as long as you eat that range of food, and the range that means that you end up having all the required nutrients that our body needs for all the building blocks in our body, both in terms of micronutrients, so all the minerals and vitamins, but also all the different types of macronutrients, all the different components, so like the fats, the proteins, the carbohydrates, and the fiber. that's fine. So that's all would fall under normal eating. If we then move on in terms from normal eating to eating disorder, there's a spectrum in between, and that's more of the disordered eating. And that's defined by a variety of abnormal eating behaviours that on their own, they wouldn't necessarily warrant an eating disorder diagnosis. So for example, that still manage to maintain a healthy weight, that still manage to meet all their nutrition requirements for the body. So that's still all fine. And yet there's something which isn't as flexible as what I've just described in the normal eating. So for example, you might have people who are overly obsessed on healthy food. So something which has come up a few years back known as orthorexia. And that then starts impacting in some way or form in the way they interact socially and starts getting in the way. Or you can have, there was another phase with people insisting on wanting to eat everything liquidized. So that again, they're still getting all the amount of nutrients, calories that they need to maintain proper growth and nutritional intake, and yet it's not completely allowing them in terms of social functioning to go out for a meal with their friends or have a pizza. So that would form and fall in the category of disordered eating. There are other forms of issues with eating, which might not necessarily be an eating disorder. So those are other things we need to think about. So we have things like depression and anxiety, which can impact on one's appetite. And just before this meeting, I've just seen a young lady who had a severe depression. One of the symptoms that she presented, yes, she did have a low weight for height. Yes, her weight dipped, but it was all triggered to how she was feeling and her low mood, which in itself causes a decrease in appetite. They might feel that they're not able to choose the food they like to eat because of peer pressure or things that they may have read on the media. They might have been that bit of comparisons. You can also have what I mentioned earlier around overeating in terms of managing your emotions. So it's thinking out, is this a binge or is this just overeating as a way of trying to regulate your emotion? And we also know people who are neurodiverse or people who have food sensitivities might have a more restrictive range of foods. So it's about the question, is that in relation to the other comorbidities that they have, so them being neurodiverse, for example, or does this go to a more extended format that they're more restrictive in their food intake, and what's driving that? Then there is all the other medical aspects which can affect appetite and cause weight loss. And these are other things that we need to exclude before, again, we jump at an eating disorder. So you can have dental problems. And the most common seen in this age group is when they have a brace. And the brace in itself can end up being very uncomfortable. It can also make it very difficult to eat. It can also cause a lot of pressure around, oh, I can't eat in front of my friends because the food all gets stuck in my braces, and that's really embarrassing. So I'm going to start skipping meals. There can be substance misuse, other medication. So if a patient has ADHD and they're treated on methylphenidate, for example, which is a stimulant medication, that in itself can cause appetite suppression. Are there physical problems? So you can have endocrine issues or even in fact gastrointestinal issues such as inflammatory bowel disease or celiac disease, which in themselves can cause weight loss. So a full screen, and also the other aspect of which I didn't mention in terms of endocrine is undiagnosed diabetes, which can also affect appetite and weight loss. So those are all other aspects we need to think about before we then jump into thinking around eating disorders. Some of the other conditions that we need to think about are infections, inflammations, Hopefully more rare in this age group would be things like cancers. And I've already mentioned earlier, thinking about other psychiatric conditions which can present with a decrease in appetite. And those are namely depression and anxiety. So we start with those, and we've done all that workup, and it's none of the organic aspects. It then leaves us to what are the types of eating disorders. So I'll just start off with maybe letting you know a bit about the epidemiology first, and then we'll move on into that. And initially, eating disorders used to be considered as the silent epidemic. That used to be a lot in a lot of schools and universities, but was very under-recognized. And I guess what is interesting from this slide, it seems a bit small to see, is maybe that about 35% will show some of these symptoms, and then there's a smaller percentage from those which then develop into a full-blown eating disorders. In fact, 35 to 57% of adolescents can have symptoms of crash dieting, fasting, even things like self-induced vomiting, and other using of diet pills or laxatives. And then from those, a proportion of those will then go on to develop an eating disorder. So I guess, hopefully, what I hope by this presentation is that you're able to tease out which are those which is it's a phase of their adolescence, and which of those have these repetitive behaviors that it then ends up being an issue in itself. And just think about some of these figures. We know that there's anorexia, bulimia, and binge eating disorder, which I'll be discussing in more detail in a bit. But what I want you to notice here is that whilst anorexia and bulimia tend to present more commonly in females than in males, it's a binge eating which tends to be more equitable in terms of sex distribution. So if we think in terms of prevalence, about 3 to 12% of adolescents actually experience some form of eating disorders, and they're usually partial syndromes, so they don't have the whole full criteria. So a lot of, when you see the prevalence of eating disorder, that fall in the category of OSFED, so that's other specified feeding and eating disorders. And whilst we know that the median age of onset is around 12 to 13 years old, and we know that there can be lower peaks, and with youngest presentations for anorexia being as young as 8 years old. However, the most common present in later adolescence and early adulthood, so between the ages of about 15 to 35. And you can see that the lifetime prevalence is the most common for the subthreshold binge eating disorder, and then binge eating disorder, with anorexia and bulimia and subthreshold anorexia being much less prevalent. However, if you then look at the next slide, which then shows us the functional impairment, the reverse is seen, with anorexia having the most functional impairment at 97%, and binge eating disorder and bulimia still having very significant functional impairment at 78 and 63%. The other risk to note is that the risk of suicidality, and whereas bulimia and subthreshold anorexia are associated more with suicidal plans, the actual suicidal attempts are more seen again with bulimia and the binge eating disorders. So when we see a patient, or when we see a child, in your case, at school, can you tell whether they have an eating disorder? Can I ask you to put some comments in the chat to that question? I might repeat that. So if you have a student in class, do you think you can tell if they have an eating disorder? Okay, very good, perfect. So whilst you do that, I'm going to start off this video, which is courtesy of Beat, just to help us understand and reflect that question.
Do you think you're very good at keeping secrets? I should say no, but I probably am quite good at keeping secrets, yeah.
So what's the best secret you've ever kept?
Couldn't tell you.
Right, see? Very good.
I think there's some really obvious physical signs that you can see when somebody has an issue with food.
Affecting teenage girls, that's very typically sort of the viewpoint that gets across.
It's tough to talk to someone about unless they're going to come and talk to you openly. What do you ask them? What do you say to them? I don't know.
Dan, you're going to ask these some lovely people. You've got 3 questions.
Yes.
To ask them if they have experience of an eating disorder.
Do you think you fit into any particular stereotype?
When I was younger, I think I tried to fit in more of a kind of stereotype, you know, when you're at school and stuff.
People always assume I'm quite loud because of the quirky way that I dress.
I guess I kind of fit into a stereotype of someone who is a bit different.
Tell me your favourite and least favourite part of your body.
I would say the favourite part would be my ears, because I like to listen.
I was about to say my hair, but my kind of my style that I can like have with my hair.
Least favourite, I would say my height.
I hate my thighs because they're chunky. Probably my ears. I don't like my knees. It's a really I know it's really.
It makes you feel a bit. I don't like mine.
What about your knees?
I think mine are all right. Like
no one needs to. Okay.
How often do you use social media?
I use it quite regularly to kind of speak to friends.
It can be a bit difficult to manage. There's a lot of comparison, so a lot of sort of competitiveness in that industry.
I'll use Snapchat, but just because I want to take funny filter pictures.
Describe yourself in 3 words.
Ooh.
That's one.
Stop it. I'm very systematic. That's probably my German kind of background. And I'm quite soppy. I cry if I'm happy. I cry if I'm sad. I'm also flaky. Most people would say I'm kind of flaky.
Okay.
Wow.
Yeah.
So Dan, we've asked all the questions. What were you feeling now?
Still a bit confused. Everyone seemed very confident, seemed to be quite direct with most of their answers.
Out of our lineup, who do you think has experience of an eating disorder?
I don't know.
I think it might be Valerie.
Okay, Valerie.
James.
James.
And maybe Chris.
Possibly Valerie and Tom?
So, anyone that has experience of an eating disorder, please could you kindly step forward?
Okay. Wow.
Everybody? Wow.
So what are you experiencing now?
Just shock, really.
Okay.
I didn't want to play into any preconceptions about skinny people or people with certain sort of sexuality or gender.
There didn't seem to be any sort of consistent, sort of similar theme.
The reason I didn't pick you was because your story was, you know, you're a yoga instructor and you're obviously quite fit.
I think it's really interesting that we think people who look well are well, and that isn't always the case.
The issue I had was, you know, because no one knew in those early stages of dealing with eating disorders that, you know, it's not just about the weight, it's about the counselling, about the mental health issue behind it.
Because it's a mental illness, you want to kind of just keep going the way you go and you think it's kind of acceptable what you're doing.
My family, they don't necessarily understand mental health or believe in therapy or understand why you're sad, like we provide everything for you. It doesn't make sense to them.
And they were the ones who went to me doctors and really kind of pushed to get me help.
Obviously growing up in an environment that's when your parents are like chalk and cheese, you kind of don't know which way to go, almost. Like, not just appearance-wise, but as a person.
I'm trying to be more open about it with my family to like kind of push other people to start talking more about mental health. So I think having someone in the family that goes through something really helps drive the conversation forward.
So I'm interested to know how many of you how you feel about those, and I don't know if you can pop some comments in the chat, whether you saw that coming or whether you were equally as surprised as the two people that were interviewed there. So, but in essence, thanks, Nikki. In essence, what I wanted to share is I hope I've convinced you enough that there's a lot of myths about eating disorder, and the main one is that you have to be thin. Another common myth is that you have to be of a certain social demographic, certain ethnic background, etc., etc. And in fact, my research interest is around looking at different cultural aspects and different nuances in eating disorders. So now let's move on to what the eating disorders are. So there are 8 types of eating disorders, and the most well-known are anorexia and bulimia. However, the most common are the other specified feeding and eating disorder and the unspecified feeding and eating disorders. And I've listed here, for those of you who haven't seen them, all the different types of the eating disorders, and we'll be touching on all of these today. And I think the main common themes is that the eating disorders come with a set of behaviours around disorder, a set of behaviours are eating disordered behaviours, and they also come with a set of eating disorder thoughts and cognitions. And it's important to manage, and when you are thinking about how to support a young person with an eating disorder, it's important to be aware of the behaviours, to be able to mitigate against these. And it's also to be important to get an understanding of these thoughts, because these are going to be very distressing, and those will be the parts where the therapy will be focusing on. So I'm going to show you another clip around an experience of an eating disorder. We might not, just because of time, we might not go through all of it, but I just wanted you to hear the story from lived experience around how eating disorder has affected this young lady's life.
Anorexia kind of takes on a persona and becomes this person in your life, rather than being something that is you. It's about separation between her and you. She's nasty. Anorexia is always nasty. If you lose a bit of weight, then for 5 minutes she's praising you and tell you that you look fabulous with this new weight loss. And then she'll go back to, but you're still fat. She is just this horrible bully that I have to live with. That's who I have to contend with all my life. Anorexia is telling me that I'm doing really, really well, and the doctors and nurses are telling me that I'm going to die. I was 15 when I got diagnosed with the anorexia. I was quite a tomboy. I mean, I was always up trees or scraping my knees and playing football and sports.
Jenny and I met in year 8. She'd stay over my house to get like movie snacks and stuff. We'd go over the road in like onesies and stupid makeup, and it's all very embarrassing. I started school and I got bullied through school, so I sort of kind of channeled my energy into my studying instead. And I had a lot of issues from the bullying about my body image and how I felt about myself. And I was always quite insecure of myself, I think, after that. I think I became kind of isolated, which then led me to study a lot. And that kind of added to the pressure of just wanting to be good enough. At college, she was like wearing baggier clothes. Like she'd wear really oversized jumpers and stuff to kind of, I guess, like hide the fact she was losing so much weight, but you could still see it in her face. She'd weigh out her food quite a lot and be like really specific on measurements. If you had a bag of crisps or like a bag of chocolate or something, you'd offer it, she'd always say no, like always.
The the anorexia began with sort of the calorie counting idea of, oh, let's stick with this many calories a day. And she manipulates you to get your calorie amount to go down each day. And as soon as I'd eaten something, I instantly wanted to exercise it off. It turns you against everyone. It doesn't want you to be friends with anyone. It doesn't want you to feel love because she acts as though she's your friend.
We was really close before the anorexia, and then when the anorexia came, it pushed us quite far apart.
Anorexia hated my mum and dad and my nan and granddad because they were the ones that was trying to help me.
Quite often Jodie would say she would hate me and want me dead. She bit me quite hard. She would pin me against the wall, but I could see it wasn't her. It was always the anorexia doing that. She was a split personality, Jodie, at that time.
Once you're in the state that Jodie was in when she was at her worst, like there was hardly any of Jodie left.
I made a doctor's appointment and we went from there, really.
I went straight from the general hospital to the inpatient unit, which was really, really hard.
It was hard because her sugar levels kept dropping. They were worried she would go into a sugar coma. Her heart rate was extremely, extremely low.
It was quite a muddle, really, is how I could describe it, because I wasn't with it a lot of the time. The doctors were telling everyone to say goodbye at this point. You know, Nan and Grandad came down and everything because they thought it was going to be their last moments with me. So the inpatient unit was quite a competitive environment. I mean, the problem is when you've got a group of girls on a table all eating together, all with the same anorexic voice, it becomes a challenge as to who can eat the slowest or who can not finish their food, who'll finish first.
Daddy and daughter making dinner. And Kat.
I had a light bulb moment after dinner. Me and my dad would always go for a walk and we'd always go around the block. And one day I got to the end of the road and I let go of his hand and he said, "What's wrong?" And I said, "Well, the anorexia is telling me I need to walk around the rest of this block. I need to complete my walk, but my heart's actually telling me I'm not going to make it there." And I think I'd crushed her instantly in that moment of, I really don't like you anymore. I don't want you in my life. I don't want you in my head. One of the biggest hurdles was the voice getting louder, because when you begin to rebel against her, obviously she's not going to like it, so she starts to scream at you and she really does get loud. I made an Instagram called Jodie Eats to Live, and that was a username decided by me, mum and dad. And we thought it was quite accurate to describe the journey I was going through.
Although I was against social media at the time, actually, it's made Jodie a stronger person.
I think her Instagram actually really helped her, like being able to document it. It was kind of like a food diary.
A fear food challenge is, you know, eating a food that you find particularly scary, whether it be sort of like a sweeter food, you know, where the sugar content's maybe a little bit higher, or more of a savoury food that is a bit starchy and makes you feel full up.
Shaking whilst putting the ham on my thin, but here is my thin.
Jodie Eats to Live kind of began as a story for myself to get through it. And then as I got through it, it became a story for me to help everyone else.
I keep motivated because I try now and look at what I didn't have and what I have and what I could have.
Now I've been weight restored for about coming up to 2 years, actually.
I just can't describe it in words, really.
Right, so that's Jodie's story, which I think she brings to life about what anorexia is and her journey much better than I can, but we will go through the diagnostic criteria. And what I've popped in the chat is she's mentioned quite a lot of signs that you as frontline workers working in schools, when you're seeing a child or an adolescent day to day, that you should be thinking about, oh, actually, that is a warning sign. And she's also mentioned, I know there are quite a few nursing staff on the call. She's also mentioned quite a few physical parameters as well, and that if we are bringing them in, getting them checked out, there are things that we need to keep in mind. can you pop in the chat, and thanks Hayley who started writing about what those signs that Jodie's mentioned are, because those will be the signs ultimately that we'll need to look out for when someone presents with anorexia. Yeah, all of those. Fantastic. So those are all there. I think the others which I heard was around the blood pressure and the heart rate when she was she had bradycardia, which means a low heart rate. And there's also, you can also get low blood pressure. Another common one is low temperature. You can get dry skin. You can get what's known as lanugo hair, which is that very, very fine, only hair, which is trying to keep the body as warm as possible. So if we move on now to the diagnostic criteria, so the diagnostic criteria have been broadened a little bit so that we make sure that people aren't missed out just because they don't have all the things. So they've made them a bit wider. So there's the restriction of energy intake in relation to what they need. So that will then lead to a low body weight, and that is in the context of their age, their sex, and their developmental trajectory. So that might differ between an adolescent or an adult or in a child, because their developmental trajectory, as a lot of you know, would go on growth centiles, and we know with the highest velocity in the growth centiles, like an S-shaped graph. So it starts slowly, then it goes very, very fast, and then it plateaus out, usually around when you hit menarche, or usually a few years later. And then it sort of remains the same, and the weight and height percentile become more stable, which is why in this age group, using BMI per se isn't very accurate. And what is a more accurate assertion, whether is this a healthy weight for height for them, is more looking at the percentage median BMI, which is the weight over the height times 100, and then it is put into proportion of the 50th centile BMI. So you have what their BMI is at the time and a comparison to what it should be, and we'd usually use the 50th centile on the BMI charts. You then have either an intense fear of gaining weight or becoming fat, and that is the more common one, the one we're more usually seeing. What I see, I work in East London clinically, what I see a lot is the second one, which is the more persistent behavior that interferes with weight gain. So it's not, this change, what it's done is not just focusing on the being able to express that intense fear, but we're also seeing observationally how the behaviors that in themselves would result in them not being able to gain weight. So I can say, oh no, I'm not afraid of gaining weight, I'm not afraid of becoming fat, but then I won't eat an appropriate portion that would allow me to gain that weight. And likewise in criterion C, you have either the disturbance in which your weight and shape concerns are experienced. So there's usually in anorexia and in bulimia actually, there's usually undue influence on body weight and shape. The other criteria, the OR criteria again, and again in different ethnicities, you tend to see one over the other. The other criterion is a persistent lack of recognition of the seriousness of the low body weight. So if we go back to thinking about what I was telling you about the percentage median BMI, so a normal percentage median BMI would usually lie around 95 to 105%. So if I tell you I've seen a patient who's about 58% weight for height, you'll know now that that is much lower. You also have to individualize it because different people of different ethnicities might sit in a different part of that spectrum, and we individualize it by looking at other biological factors and how their body is responding to that weight. So the most easy example is in a postmenarchal female, which means a female who's already had and started her periods. So the return of menses, so the return of her periods, is usually a sign that her body is happy at that weight. So pulling all of those together, those will help us know whether the young person who's presenting to us suffers from anorexia. So what I was coming to is, if I gave you the example of the young lady, she was of Bangladeshi origin, she was 58% weight for height, she wasn't menstruating. So from all the things I've told you, you already know 58% weight for height is very low. We've put it into context of her body. Is her body happy at that weight? We know her body isn't happy at that weight because she's not menstruating. And she's sitting there in front of me and telling me, but I don't see what's all this fuss about. I think I'm okay with my weight. That is showing, and she doesn't have, I don't have a fear of gaining weight or etc. So that is showing me that she definitely has criterion A, because we're saying she's 58% weight for height. She doesn't fit the either part of B, so she doesn't fit the intense fear of gaining weight because she's not voicing it, but she's not doing anything and she's not able to increase her portions in any way. So she fits the OR variable, the persistent behavior that interferes with weight gain. She also doesn't fit the first bit of criterion C, but she does fit the OR bit of criterion C, which is the persistent lack of recognition of the seriousness of low body weight. With anorexia, you can have two subtypes. You can have a restricting subtype, or you can have a binge eating or a purging subtype. The difference between these two is exactly what it says, whether you have binge eating or purging behavior within the last 3 months. If we think about etiology, there is a mixture of genetic and environmental causes. We know that chromosome 1 in particular is linked to anorexia. And we also know that at puberty, there seems to be a switching on of some of the interactions, because we know that that's where the peak incidence occurs. But we also know that environmental factors, including factors around pregnancy, maternal distress, young person distress, and attachment styles, especially insecure attachments, can also affect anorexia. Social media and body image ideals also impact. And we also know that certain individual perfectionistic tendencies and personality traits affect. High expressed emotion in families is also known to affect, but none of these characteristics and etiological factors on their own can result in anorexia. And it's usually a combination of them that interacts together and results in the switch from dieting to then becoming a more extreme version, and it's having a life of its own and developing anorexia. So let's think now about bulimia. And I chose this clip because it presents a picture of type 1 diabetes, insulin misuse, and bulimia, which is one of the most riskiest forms of purging behaviors in bulimia. And I just wanted to alert people that this doesn't have a good outcome. So if you feel triggered or anyway, maybe come back in the next couple of minutes.
Only 1 week and 1 day until my birthday. Yeah, yippee. Can't wait. I really love Sam. I don't see how he could love me though, because I'm just so fat and ugly. I feel really fat. I want to lose weight. I think I'm about 9 stone. I had bacon and sausages for tea, and then I made myself sick and threw it all up. I had a long text talk with Mike, but I don't love him. I rang Sam. I love him. I am so pleased and I feel great. I haven't eaten chocolate in 4 days and I've lost half a stone. Mike texted me last night and everything is good. I weigh 55.8 kilos. I think I'm bulimic. I've had a really bad hypo at lunch. I was sitting with Mike and his girlfriend. I don't think he thinks I'm fit anymore. I collapsed on Saturday because I was having a hypo. I was unconscious for about 10 minutes. I've done loads of revising today because my SATs start tomorrow. Going to the gym, like every day. I can't do anything more, or I'll die of exhaustion. But maybe that's a good thing.
Any comments? Any thoughts? Anything people could have done, noticed, or? Absolutely, and that's why I keep that clip in, because it's very touching, disturbing, and it really makes us remember that actually, yes, anorexia is linked to the most deaths, with 1 in 5 being from suicide and 4 in 5 being from medical causes. But it's very easy to overlook that actually even other eating disorders, particularly bulimia, particularly those associated with complications of the purging behaviour, also result in deaths. I'm going to need to move us on, despite it being a very touching clip, to think a little bit about the diagnostic criteria for bulimia. So in bulimia, you have 2 components. You have the binge eating, and I've written there, which you can read, about what binge is and how that's different. There are certain criteria which make a binge different from just overeating. And then that binge, which is usually associated with lack of control and guilt, is then followed by a compensatory behavior. Now, the compensatory behavior can be any behavior that can be used to prevent weight gain. That the most common one that we know is, or that we know that is known of, is self-induced vomiting, but that's not the only one. It can range from anything like misuse of laxative, dietable use, diuretic use of other medications. Insulin is one of them. The other common one that's used is thyroxine, which uses to speed up our metabolism. But it can also be things like fasting. So you can have a binge and then you can fast as a result, then you have another binge. That's additionally also risky because of the fluctuations in electrolytes that you have from the 2 extremes. Or you can also have things like excessive exercise. That would also count as a compensatory behavior to the binge. In bulimia, like in binge eating disorder, which is the next on the list, you're going to have these sets of behavior for a minimum of at least once a week for 3 months. Like anorexia, bulimia also have a self-evaluation, which is usually influenced by weight and shape. And you know, I've mentioned the binge or the purge type of anorexia. So again, you can't have bulimia and anorexia coexisting. So you need to be able to tease out whether it's one or the other. And there are a number of aspects to how to tease that out. It's to see if Do they binge and do they purge? Are they both? What is the cognitions behind it? Is it the thought of wanting to get rid of food, or is it just driven on trying to lose weight? And then there's also at what weight for height are they? You tend to find people with bulimia either being at an overweight or at a normal weight, whereas people with anorexia, as we saw before, the first criterion was they have to be at a low weight for height for them. So again, if we think about the etiology of bulimia, you have a mixture again, you have a mixture of environmental and genetic factors. We know that there is this vicious cycle, which the binge purge cycle and dieting, hunger and eating and then purging, then you end up finding it very difficult to break. We also know one of the treatments is fluoxetine, and we also know that that works on serotonin, so that there is a component that serotonin plays a role in this. So where does obesity sit in all this? Is that an eating disorder? What do you think? We have some answers in the chat. Do you think obesity is an eating disorder? Okay. Okay. So very interesting. So quite a range of people. Some people, a lot of people said yes. A few people said no. Some sit on the fence, say in between. So obesity actually is not an eating disorder, but it can be one of the symptoms of an eating disorder. So for example, if you have binge eating disorder, patients with binge eating disorder can tend to be more on the obese side because you're having the binges, which is a large proportion of food which is usually consumed in a short period of time, associated with a lack of control, feeling of being uncomfortably full and a lot of guilt after, but no compensatory behavior. And it's usually associated with a lot of emotion, it's distress. So obesity itself isn't. It's like you're saying a low weight for height. It's a symptom, but it's not an eating disorder per se, but binge eating disorder would be. And again, like in bulimia, you have to have that the binges occur for at least once a week for a period of 3 months. If we think about the etiological factors, once again, we know that there is a mix between the genetic and the environmental factors. We also know that chronic dieting tends to also predispose someone to then end up having a dysregulation and then in their food intake, which then again causes a cascade and triggers binge eating. So one of the most important aspects in binge eating is making sure that you reinstate regular eating. So moving on to the ARFID, which probably is one of the lesser common known. It used to be called Feeding and Eating Disorders of Childhood. It's now been amended, changed, updated, whichever you want to say, included in the DSM-5 and being extended to include all the age spans. So ARFID is no longer just the diagnosis that we think about in children and adolescents, but you can see it across the board. And in people with ARFID, you can have a range of weight size. So you can have people with ARFID who are very, very low in weight. You can have people with ARFID who are normal weight, people with ARFID who are overweight. The main aspects of ARFID is that they need to have either growth or nutritional deficiencies associated with one of 4 components, which I'll come on to the next slide. But very importantly, especially in the underweight ARFIDs, is to make sure that there isn't any weight and shape concerns, because otherwise that's not ARFID, that's automatically anorexia. And the other thing to note is that some individuals, especially those with autistic spectrum condition, anxiety, or who have had maybe an episode of a life-threatening episode or a very embarrassing episode relating to food and eating. So for example, I've had children who have nearly choked on their food and then they develop a phobic subtype of ARFID. So that's one of the aspects that you can have. So these were the criteria which I was mentioning. So again, as I was saying, you have to have the first bullet point is very important, so persistent failure to meet appropriate nutritional and or energy needs. So for example, one of the 11-year-olds that no, she's younger actually, I say, she is 6-year-old, so I was saying I've recently diagnosed. She just drank milk, and you say, oh, milk is amazing, it's really good, it's really nutrition. Yes, it is, but if you only drink milk, that doesn't give you all the macro and micronutrients that your body needs. In fact, she ended up being very anemic, needing iron supplements, and I'm working very closely with the pediatrician to see actually does she need also a blood transfusion. Another boy who I've seen similar age eats a wider variety, but eats less of different foods, and you can see again he's not meeting his growth needs. So those two would fall in the criteria, and then you need to have at least one of the other. So either significant weight loss, so in children you'd see more of faltering growth or failure to gain weight, significant nutritional deficiency, and I emphasize the word significant. So just having a low vitamin D or just having one micronutrient which is low, I think you need to see the context. You need to be sure that this is a significant and that this is away from the population norm. And it has to be linked with a restriction in their diet. The other thing that you can see is the dependence on enteral feeding. So they tend to be having shakes or supplements or things like Fortisip, which are oral nutritional supplements, to supplement what they eat because they're not eating enough. So the parents are getting worried, going to the pharmacist, trying to see how can they help their child who they're worrying who's eating so little. The other aspect is the marked interference with psychosocial functioning. And again, I'll emphasize the word marked. And this is usually things like parents needing to phone up the restaurants, get the menu, make sure that there's something that they can eat, like the boy who only eats chips in the next slides, and seeing is that available and adapting where they go, or not being able to go out with their friends because they won't be able to eat. And as I said, the most important thing is looking at those nutritional and growth aspects, because actually the nutritional deficiencies can actually lead to some very severe side effects, and that's why we need to respond, assess, diagnose, and intervene as early as possible. I'm just going to touch on these just for completeness sake. So there's rumination disorder, which is the repeated and involuntary regurgitation of undigested food. It's not used as a means of losing or controlling weight. And it usually typically occurs about 1 to 2 hours after completing a meal, though some other patients might experience symptoms episodically. I think the important thing to note about this is it rumination disorder, or is it that they had bulimia, they've been vomiting for a lot of time, so they've just loosened the sphincter between the stomach and the food pipe that we have. So it's important to see what's what and what came first, etc. I think patients with rumination disorder tend to present first to the GI clinic, and then we tend to then get a referral thereafter. But just for you to know. And then the other thing, just to mention, is just PICA, which is the persistent eating of non-nutritious, non-food substances for a period of at least 1 month. So whereas for bulimia and binge eating disorder, the minimum time period was 3 months, for PICA, it is 1 month. The important thing around PICA is to make sure that this is not at the developmental, that is at an inappropriate developmental age. So this would automatically exclude the toddlers when they're teething and where they're exploring and they're putting things in their mouth as an exploration. That's not PICA. So just keep that in mind. Okay, so I just want to think around when would you think about referring people. So I've popped here, this is a piece of work that I did together with my colleagues at the Healthy London Partnership, and we've produced this guideline. It's mainly for GPs and primary care professionals. I think it's a useful guideline for anyone who has interaction with children and adolescents, and it includes the red flags, which are on your bottom left of your screen, which are things which you should really be picking up the phone and being worried about. And mainly it's about not eating or food refusal for more than 24 hours, fluid refusal for more than 24 hours. If you notice any blood pressure or pulse changes which are causing compromise or fainting, a very low weight for height, very low blood pressure, a very low heart rate, and a low temperature. The other thing in terms of weight loss is if you have a weight loss of more than 1 kilogram a week for at least 2 consecutive weeks, that again puts it in the higher risk category. But what do you do if you have a, yes, Caroline, it can be accessed online. If you just pop in the title and do Healthy London Partnership, it'll come up. What do you do if you're a school nurse and one of the teachers or parents is worried about the children? I would suggest doing, first and foremost, a basic physical examination. And when I say basic, it's what I wrote in the top right-hand corner, so at least a weight and a height and the date of when you've taken those so that we can start monitoring it. I'd do a blood pressure and pulse, and I would do those both sitting and standing because the risk is also associated with the changes between sitting and standing, and whether there is a drop in heart rate, an increase in heart rate or a drop in blood pressure associated. So that's one of the prognostic indicators around how much to worry. I'll do a temperature, and then you can do some blood tests if you want. I think the main, if you have to do, there are quite a few blood tests that we had written at the time. I think if you want to do even less, I think the key ones would be the full blood count, a kidney function, a bone profile, and an albumin level. So I think those would be the very key ones, because those are the ones which will give us an indication of risk and give us an indication of how high is the risk of refeeding if we're going to reintroduce food. And it will also, the kidney function and the bone profile will also give us an indication of if there's been any purging. Are there any aspects, especially in the potassium, which is the electrolyte that we are most worried about in purging, what that is. The other thing in purging to be aware of is purging, any form of purging, both vomiting, laxative misuse, any form, well, vomiting or laxative misuse, not any form actually, not the over-exercise, is around the highest risk with that is also dehydration, which in itself can also affect your kidneys. So those are things to think about. If you're a school nurse, a very, very good document to read is the Medical Emergencies in Eating Disorder, which can be found from the Royal College of Psychiatry website, which we just released May of this year, actually. And there are also one page we've added this year, and it used to be called Marspin, for those of you who heard of that. It's now called Mead, because we had a service user and parent panel who wanted to change the name and found that more helpful. The other thing that we've added is we've added lots of appendices, which are one-page sheets, about one page. I think there is for school nurses as well. So what to do if you're a school nurse, what to do if you're an A&E, what to do if you're a general psychiatrist, what to do. Yeah, so just one-page sheets, which are really useful and handy. So I feel I'm talking very fast. Oh, what was it called again, Hayley? So it's called MEAD. I'll pop it in the chat. Which stands for Medical Emergencies of Eating Disorders. So I'm not going to go into detail about the management plan, but I've put one slide for you to be able to have a look at what the different types of management that you can have. The mainstay is family-based treatment. Oops, what I do is family-based treatment for eating disorders. But there are also some if that's not a appropriate for whatever reason, you can then think about individual therapy. And the most common is either cognitive behavioral therapy for eating disorders, but you can also have adolescent focused therapy, and that's specifically for anorexia. In terms of medication, medication is doesn't tend to be the first line treatment, but sometimes you can use medication if the therapy is not enough and does not suffice. I think the most important things with eating disorders is not to delay going from one step to the other, because you can always reel back if the patient manages to turn a corner. So I usually tend to say, if you have an increase in weight in the first 4 weeks, so about 2.5 kilos in the first 4 weeks in anorexia, then that's fine. If not, I think I would start escalating. I'm thinking, well, okay, well, that's not enough. So what else? What's happening? And I usually do it in the form of going back, taking stock, having a professional meeting and thinking, what else is going on for this family? Do we need to give additional support, which could be the family-based treatment plus an individual therapy, or it could also be thinking about maybe starting medication at that point, or starting those discussions and stepping things up slowly. And I've put a very quick snapshot of what the NICE guideline says. And as I was saying, the first line is family-based treatment. Second line would be the CBT, or the adolescent-focused psychotherapy for anorexia. Whereas for bulimia, it's more the bulimia, again, family treatment and the CBT. In terms of binge eating disorders, the first mainstay would be more of a guided self-help, followed by group CBT, E, and then individual CBT-E. I'm not going to go through the additional reading. I think I've managed to stick to time. But basically what I've added here is thinking around what NICE guidelines say. And this you can read in your own time. So I've given you the ones for the anorexia aspects, the bulimia aspects, and the binge eating disorder aspects there. And just a mention of ARFID, because we did say it was the more common, and the management plans are very similar to the treatments that it most closely resembles. In terms of ARFID, the only other aspect that we haven't actually covered here, I should remember to add it to the slides, is thinking about purging disorder as well, which is the opposite of binge eating, where you have the purging component, but you don't have the binges. But it's still not a formalized diagnosis per se, like anorexia and bulimia, and it's only mentioned in the ARFID section on the DSM. So I don't know if you have any questions, and that's just my disclosure of the slides. So I'll stop sharing and I'll hand over to Dennis.
Erica, thank you so much for this wonderful. I've certainly learned a lot, so thank you for sharing this. There was a couple of questions about the videos, whether you thought it would be useful to show these videos to either children or their family members.
I probably wouldn't show these particular ones to family members, or well, family members maybe, but I think there are more let's put it this way, I think there are more useful videos to show to families and more useful videos to show to young people. I think some young people, I think it depends on which ones. I think it depends on which ones. The anorexic one might be helpful because it's someone relaying, and it would be exactly the same like when we have an ambassador coming in to speak at schools. The bulimia one, I don't know, it might be a bit triggering and a bit shocking for them. There are very good other videos on the Beat website and on the Maudsley website, and there's also the Kelty site, which are probably more appropriate for parents and young people.
Questions about the slides? Yes, they will be available in PDF format. Two questions. One was about the management of ARFID when co-caring with ASD. Could you say a few words about that?
Yes, so the management of ARFID is, again, very little evidence-based, just research is up and coming. The therapeutic approaches that are used are family treatment for ARFID or CBT for ARFID, which uses more of the behavioural aspect. So in ASD, we tend to find that maybe the CBT aspects tends to work a little bit better than the family approach. But it depends. In terms of then stepping it up with medication, again, not a lot of evidence-based, but off-license, off-label. The one with the most evidence behind it is mirtazapine.
Interesting. And then I think the final question I was able to pick up was about rumination disorders, and a little bit more about when they start and what to do about them.
So with rumination disorder, it's working very closely with the gastroenterology team. And one of the first things to do is to do a manometry test to see whether this is actually rumination disorder, exploring whether this is in combination to a previous history of bulimia, or whether this preceded it, or whether it's preceded a history of anorexia, or whether this preceded it, because that will change the management plan. To start off, you can start off with some very basic breathing techniques, deep breathing techniques to try and strengthen the sphincter, the gastroesophageal sphincter. If that doesn't work, then it's thinking about CBT for rumination disorder, or thinking, and then if all fails and you need to step up, you can think about adding on some medication.
I think that's all the questions I was able to pick up. So with that, Eric, I wanted to thank you one more time for this wonderful, wonderful overview. Thank you also for making your slides available to everybody. And we hope that you'll be happy to come back and speak a little bit more about this very important and really often misunderstood topic. Thank you so much, and thank you for everybody.
Pleasure. Thank you all for listening.